The next topic for us in surgery, or general surgery, we should say, is sinus and fistula discussion. Now, these are the very basic topics, just like abscess, just like any general infections of the skin and subcutaneous tissue, ulcer, wound. These are all very basic topics. So here is another one for you, that is sinus and fistula. So in this topic, we'll talk about what are the definitions or meanings of sinus and fistula to start with. Then what are the classification or the causes, how to take history, how to do physical examination, and then what are the investigation we'll order, and finally, what is the treatment. Let's move on. So sinus is a blind tract which is usually lined by our granulation tissue leading from an epithelial surface into the surrounding tissue. This is sinus. So it is a blind tract. Blind tract means there is only one opening, okay, on one side only. Another opening is closed. It is not open. So if I put a tract, okay, if I put something inside the sinus tract, it will only go inside, but it doesn't come out from the other side because that side is blind. This is sinus. The Latin term for the sinus is a hollow. Pathological sinuses must be distinguished from the normal anatomical sinuses, and you have studied this probably, maybe heard the name, okay, at least. Paranasal sinuses, and there are four: frontal sinus, maxillary sinus, ethmoid sinus, and sphenoid sinus. These are the normal anatomical sinuses in our body. Okay, these sinuses are actually a cavity. There is a big cavity, and there is one channel which leads into this cavity. These are very different type of terms, though the name is sinus, which is quite confusing for the student, but these are normal anatomical structure which are present in our body. Now, before we move further, please focus on the slide. This is the schematic diagram of sinus, and this is the fistula. Okay, see there? Yes, this is a blind. Okay, this is a blind track. Only one end is opened here. This is a blind one. Whereas on the other side, both the ends are open. Here is a one opening. Here is another one, and this has led into other lumen. Okay, probably this is the intestine. So this is a lumen. So this is a fistula. So to make it very easy, one end of the sinus is only open, another end is blind or closed, whereas in fistula, both ends are open. Now, after looking at that picture, the definition or meaning of fistula is very easy. A fistula is an abnormal communication between the lumen or surface of one organ and the lumen or surface of another, or sometimes they can be connection between the blood vessels also. If they are between the blood vessels, okay, we call them usually like arteriovenous fistula, between the artery and the vein. AV fistula is a very commonly used term. Most fistula connect epithelial lined surfaces, either outside or outer part of the skin to the lumen of the intestine, or something like that. Okay, there are so many different examples you can take. Now, what are the types? See here, sinuses and fistula, they may be congenital or acquired. Congenital means from the time of birth, these sinuses or fistula are present. Some of the examples are pre-auricular sinuses. Now, what is this auricle means? This auricle is what?
Valve.
Okay. This auricular is external ear. External ear. External ear. Okay. The auricle, the meaning of auricle is external ear here. So there are so many people who develop a small sinus in front of their pinna or external ear. So let me write that for you, because the auricle term is also used as a part of atrium, isn't it? That's why sometimes students are confused. So this is in front of the pinna or external ear. So pre-auricular sinus, very common in general population. Branchial fistula. Now there are branchial arches. We know that we have studied in embryology, branchial arch. So there's fistula present near the neck area, okay, on the side of the neck, and the very near to the sternocleidomastoid muscle. If there are fistula present, usually they are congenital, and we call them branchial fistula. Tracheoesophageal fistula. Many students know that because we have studied this in pathology lecture. Tracheoesophageal fistula. It's a part of esophageal atresia syndrome. And the real meaning is there is a connection between trachea and esophagus. Okay, this is tracheoesophageal fistula. It can be acquired, but usually it is congenital. Now, what is the danger of this tracheoesophageal fistula? Every student can answer this. There is a high
Food
risk
can
of
pass into the
Aspiration,
air.
sir. Aspiration.
very good. There is a risk of aspiration. Excellent. You can easily say that there is a risk of aspiration, and sometimes what happens is the food directly can pass towards the trachea. It depends on what type of tracheoesophageal fistula we are talking about. But more commonly, the esophagus is blind here, that is esophageal atresia, and the blind tube get filled up with the saliva, and then that saliva is trickled forward into the trachea. This is more common than food directly going into the trachea. Arteriovenous fistula. This is also a congenital one. Inside our body, in so many different places, this can be present. And one of the very important point regarding arteriovenous fistula is it can rupture and bleed, or it can give pressure to the nearby area. Let's move further. Now, on the other hand, what are the types of acquired sinus or fistula? Acquired. They're not present at the time of birth. They are formed later on in life. So they may follow inadequate drainage of an abscess. Inadequate drainage of an abscess. Now, what happens here? Sometimes the abscess can rupture on its own, and pus will be drained outside, but the cavity still remains there. Okay. Perianal abscess may burst on the surface and lead to a sinus. Perianal abscess around the anal canal. Perianal abscess, quite common in the general population, and this is a very serious type of abscess because it can easily give rise to sinus or even fistula. Abscess opens both into the anal canal and onto the surface of the perineal skin, can result in fistula in ano, an important topic which we will teach you in GI system. Okay, fistula in ano. Now, in ano means it is around the anal canal, that's the term, and this is a fistula. Fistula has two openings on either side. So one opening probably on the surface of the skin and another opening into the anal canal. And usually the cause is again rupture or burst perianal abscess. Another good example or type of acquired type of fistula is acquired arteriovenous fistula, which are caused by trauma or operation. They are very commonly caused by operation rather than trauma. For renal dialysis or hemodialysis, the surgeon, they create one artificial, okay, arteriovenous fistula there. It's later on they will form the arteriovenous fistula on the wrist area, on the wrist, okay, so that they can easily go for hemodialysis later on. So many times they can repeat from the same area for hemodialysis. Because let's talk a little bit about hemodialysis. You must be knowing about this. If a person is having chronic renal failure, especially in the end stage renal disease, two types of treatments can save the life of that patient. One is hemodialysis, which should be done regularly, probably 3 times every week, at least 3 times every week, and that should be continued throughout the life until and unless the person can transplant the kidney. So definitely the second form of therapy is renal transplantation. But renal transplantation is not that easy thing, isn't it? You need a donor first. You need a very good center for the renal transplantation. And third, you need to have good amount of money as well. So many people are in this world who cannot go for renal transplantation even after they develop chronic renal failure. So what is the option for them? Dialysis, hemodialysis regularly. And for that, okay, the doctor will create arteriovenous fistula on the forearm near the wrist area, and they can go for renal dialysis after that. Now let's move on. Another very important part of this lecture is what are the causes of persistence of a sinus or fistula. In this situation, the sinus or fistula, after they are formed, okay, there is no early healing. They will persist for a long time until and unless we go for definitive type of treatment. So what are the causes? If there is presence of a foreign body or necrotic tissue like a suture, hair, or a sequestrum, which is called dead bone, in some particular area, then there is a high chance of development of sinus or fistula, and it will not heal. It has already formed, remember that, but it will not heal in time, okay? It will persist for a longer duration. Now there is a new term for you, it's called sequestrum. Now sequestrum is called as dead bone. Now can you tell me which is that condition where a dead bone is developed or dead bone is formed? Yes, what is that situation or condition where a bone is dead? Who can answer this? It's a very easy question I'm asking, okay? The answer is not that difficult.
So there's an ischemic zone out there, sir. Then it's a sort of ischemic like area.
Yeah, ischemia, you can say ischemia ischemia of that particular bone, isn't it? If there is no blood flow, just like any other tissue, the bone will also die, okay? So ischemia of that particular bone can lead to dead bone, and that is called sequestrum. But the point which I like to mention here is not that, it is something different, and that is chronic osteomyelitis. So let me write it for you here. In chronic osteomyelitis, here chronic osteomyelitis, the chance of sequestrum is very, very common. There's a sequestrum. Sequestrum is called dead bone. Now there is another term also in chronic osteomyelitis which is called involucrum. Involucrum is a new bone formation. At the same time, some of the bony shells which are present there will try to form the new bone, that is called involucrum, and sequestrum is the dead bone, okay, which is very common in chronic osteomyelitis. But even if you say in any case of ischemia or the very poor blood supply, a bone can be dead, and that is still known as sequestrum. Let's move on. If there is inefficient drainage, okay, inefficient drainage like a long narrow tortuous track, some amount of fluid is always remaining there, then also the sinus or fistula is going to persist. They are not going to heal. And especially if that drainage is an infected one, there is high chance of persistence. Another cause is high pressure. The pressure situation, like in fistula in ano, due to contraction of the sphincter which is around the anals. This force the fecal matter skip through the fistula, and whenever the fecal matter goes out through that fistula's tract, it is never going to heal. It is never going to disappear on its own. It is going to persist. Okay, so this has to be treated by surgery. There's no other way. We have to remove that fistulous tract. This very important topic called fistula in ano, will deal this in our GI surgery classes. Another cause of persistence of sinus or fistula would be dense fibrosis, which prevents contraction and healing. This dense fibrosis can occur in chronic type of sinus or fistula. Some of the specific type of infection like tuberculosis results in sinus formation. Very common cause for sinus is a tuberculosis. Now, TB will cause cold abscess formation, and that cold abscess can rupture and lead to sinus. The presence of malignancy or malignant disease is another common cause of sinus or fistula and persistence of it as well. Let's move on. Ischemia. Ischemia is definitely a cause of persistence of sinus or fistula because of poor blood flow. The tissue is not going to heal. Use of drugs like steroid and cytotoxic. What is the common, nature of both these drugs, steroid and cytotoxic, and why they are mentioned here? Yes.
Decrease the immune system.
Immune suppression.
Very good. I already got the answer. Excellent. Every students are trying to say the same thing. Decrease, okay, immunity or immunosuppression or decrease inflammatory reaction. Very good. So all of these meaning the same thing. Steroid and cytotoxic, they decrease the inflammation, and we need to have inflammation for the tissue healing. So if that inflammation is reduced, the sinus or fistula is going to persist. Malnutrition, another immunosuppressive condition. Irradiation, okay, irradiation, it can cause sinus or fistula because of different reason, or it can also lead to persistence, like rectovaginal fistula after treatment for a carcinoma of the cervix. This carcinoma of the cervix is very common cancer in female. In some of the country, it is the commonest cancer of the female. But all over the world, if they ask you this question, you can confidently answer carcinoma of the breast is the most common cancer in female all over the world. If I take the data from many countries in the world and mix that data together, carcinoma of breast will be the #1. But in the South Asian countries from where most of us belong, okay, Pakistan, Nepal, India, all these countries, carcinoma of the cervix is very, very common cancer in female. And there are different ways of treatment. One is surgery, another is radiotherapy, and another is chemotherapy. Now, irradiation means radiotherapy. So some of the adverse effect of this radiotherapy would be formation of rectovaginal fistula, or even surgery can lead to the formation of that. So rectovaginal, see that the fistula's connection is between rectum and vagina. Crohn's disease. So what is Crohn's disease?
Is a type
inflammatory
bowel
disease.
It causes
It's
of your
inflammation
digestive
of the
tract,
digestive system.
can lead to
Where
pain,
pain,
diarrhea, fatigue, weight loss.
abdominal fatigue.
Very good. Very good. Okay, excellent. You guys are quite fresh regarding Crohn's disease. If you just say it's a type of inflammatory bowel disease, your answer would be accepted. Okay, we don't want a detail here, but it is a chronic type of disease where severe damage occurs in our GI tract. This is a granulomatous inflammation. Okay, granulomatous inflammation which involves all layers of the bowel. That's why there is a high chance of fistula formation in Crohn's disease. And that fistula is a very interesting one. It can form between different organs inside the abdomen. Sometimes it forms between the bowel to bowel. Okay, so let me mention some of the fistula which can form in Crohn's disease. Now see that. Okay, so if the fistula forms between a small intestine and large intestine, small intestine and large intestine. For example, ileum of the small intestine, we call it ileo, and we call colon for the large intestine. So ileocolonic fistula is one of the good example here. Ileocolonic fistula. Another one, okay, jejunal fistula. What do you mean by that? Between two loops of the jejunum. Jejunal fistula, jejunoileal fistula, jejunocolonic fistula, and sometimes it can also be rectovaginal fistula. Rectovaginal fistula. Now this is a very difficult situation for that female. There is a fistulous tract between rectum and vagina, and some of the fecal matter may skip through the vagina also. So these are very difficult condition to handle. Okay, so a quite common question in the exam. Complications of Crohn's disease are different fistula connection. Now there is another a cause for high output fistula, and the important example for that is duodenocutaneous fistula, between the duodenum and the outer skin, and a lot of fluid, I should not say IV fluid, a lot of fluid may leak from that duodenocutaneous fistula outside. That's why the term high output fistula. Now let me ask you one question. The second part of the duodenum receives one of the very important production from the liver or gallbladder. What is that?
Bile.
And from,
Bile.
very good. And from the pancreas also, through the pancreatic duct, there is pancreatic juice, isn't it? Pancreatic juice and the bile. So if there is a fistula in the fourth part of the duodenum or third part of the duodenum, which is connecting outwards to the skin, a lot of these fluid may leak outside. That's why high output fistula. Now we are reaching to a very important part of this lecture, that is clinical examination of the patient. So please pay attention here. So we discuss this clinical examination under different headings. Let's inspect that first. Inspection, just the observation. Well, according to the location of these sinuses and fistula, we can get the diagnosis just based on the location. See here, pre-auricular sinus is present at the root of helix of the ear. So I already told you this auricular is another term for pinna or external ear. So in front of the external ear, the sinus may be present. This is called pre-auricular. Helix of the ear is one of the part of external ear. Median mental is at the symphysis mentae. Symphysis mentae means we have got jaw, so exactly the midline, okay, of the lower jaw is called symphysis mentae joint. So the two parts of the lower jaw will be connected there. So if a sinus is formed there, we call it median mental sinus. And the neck, sinuses due to tuberculosis is very common, because tuberculosis usually leads to lymphadenitis on the neck, and that lymph node will be converted into cold abscess, and that cold abscess ruptures outside. So sinus on the neck very commonly caused by tuberculosis. And which type of tuberculosis? There are so many different forms of tuberculosis. So answer very confidently, this is tuberculosis of the lymph gland or lymph node. Pilonidal sinus, you must have heard this term before. Pilonidal sinus is formed near the cleft of the buttock, okay, near the cleft of the buttock, slightly on the upper side of the buttock near the natal cleft. There is a sinus known as pilonidal sinus, and usually there is a hair growth in that pilonidal sinus, and repeatedly it can be infected and it can give a lot of trouble to the patient. It's quite common in hairy person. Now, what about the fistula? according to the location, this fistula can be diagnosed. Like branchial fistula, it is present in the anterior border of sternocleidomastoid muscle. Now we all know where is sternocleidomastoid muscle, isn't it? It is on the side of the neck, on the side of the neck, sternomastoid, or you can say sternocleidomastoid muscle. Do you know what is the nerve supply of sternocleidomastoid muscle? Anybody?
Sir, by the accessory nerve, sir. Sir, by the
Very,
C2, C3, sir.
very good. Accessory, just say accessory nerve. Excellent answer. Accessory nerve. This is the 11th cranial nerve that supply sternocleidomastoid muscle. Very good. This is an extra question. This is not in relation with our topic. Okay, I'm just asking this. Now listen. Pay attention here. The branchial fistula, the opening, the outer opening is present at the anterior border of sternocleidomastoid muscle. That is the meaning. And sometimes some discharge may be there. Parotid fistula is seen in parotid region. Now, where is parotid gland present? Where is the location of parotid gland?
Below the ear.
Okay.
Yeah.
Now, so remember one very easy way I will teach you here. Okay, then you will never forget it. The parotid gland is present, okay, in between pinna means external ear, and okay, and the ramus of mandible. Between the pinna and the ramus of the mandible. Now ramus of the mandible means it's the vertical part of mandible bone. Mandible bone has two important parts, the horizontal part and the vertical part. The vertical part is called ramus of the mandible, that is present anteriorly, and pinna is present posteriorly, and in between these structure the parotid gland is present. This parotid gland is the biggest of salivary gland in our body. Other salivary glands are submandibular and sublingual salivary gland. This parotid gland has a duct. This is called parotid duct, which opens into the oral cavity. So these are some of the important information for you. And okay, let me talk a little bit more because this is an interesting thing for you. If parotid gland is swollen or infected, and there is one virus which very commonly infect parotid gland and result in parotitis. What is the name of that virus?
Mumps.
Mumps. Very good. This is mumps virus. Okay, it is a very painful condition because the anterior surface of the parotid gland has a very dense fibrous tissue. So parotid glands cannot be swollen, anteriorly or on the surface. That's why it is a very painful condition if somebody develops mumps. Now, another important type of fistula is a thyroglossal fistula. This is also very interesting situation, thyroglossal fistula. So before we talked about this, we need to go back into the embryology. We need to know a little bit about development of the thyroid gland. Now listen carefully here. Thyroid gland is developed, okay, from the oral cavity. The origin of the thyroid gland. Oh, Aziz ur Rahman. Okay, I muted him. Now, so what I was talking here is thyroglossal fistula. So we should know about the development of thyroid gland first. Okay, the thyroid gland is developed from the oral cavity. To be very specific, it develops from the tongue area. There is a foramen cecum at the tongue. This foramen cecum is the junction between anterior 2/3 and posterior 1/3 of the tongue, exactly at that site. From there, the thyroglossal duct will originate, and this thyroglossal duct will go distally towards the neck. Now, when it reaches exact site where thyroid gland is developed, exactly that site, it will bifurcate into two parts, and each of these bifurcation will develop into two lobe of the thyroid gland, and the connection is developed into isthmus. So thyroid gland has two lobe and the connector part, which is called isthmus. Now what will happen to that thyroglossal duct? Now it should disappear. Normally it should disappear. Somehow if it doesn't disappear, it can lead to thyroglossal cyst or thyroglossal fistula. This is the meaning. Thyroglossal cyst or fistula. Cyst is much more common than this fistula. Okay. So naturally it may be present a midline of the neck below the hyoid bone, because that is the common site for thyroglossal duct. Now, one very important practical point: how do you know this is a thyroglossal cyst or thyroglossal fistula? You ask that patient to show the tongue or to stick out the tongue. Now, if they stick out the tongue, and if there is a movement of this fistulous tract or thyroglossal cyst upward, okay, then you almost get the diagnosis this is connected with thyroglossal duct. Now why? Because remember, the origin of thyroglossal duct, it is from the tongue. So when you stick the tongue out, okay, the structure which is connected to that thyroglossal duct is pulled upward. That's why it is moving. This is a very, very important clinical test we do to know whether this is thyroglossal cyst or thyroglossal fistula. Now after this discussion, let's look some of the picture here. Okay, all of you please focus on the slide. See that? Now this is pinna. Okay, the first picture, this is pinna or the external ear. This is called helix. This part is called helix of the external ear. This is called antihelix. Okay, this is called tragus, tragus of the external ear. Now what can you see here? What is this? Now see that this area where I'm pointing it. What is this? See this? Yes?
Sinus.
Exactly. Okay, this is pre-auricular sinus. This is auricle. This is in front of the auricle. So pre-auricular sinus. It is already infected. You can see there's some pus discharge from the opening. So I have to clean this pus first, and then only I can see the sinus tract. So this is an important point. Okay, this is very common. This may be congenital, but it is infected secondarily. Now see this. Okay, the second picture here, this is the lower lip. So this is called mandible. This is the mandible. This is the horizontal part of the mandible of the right side, and here is the left side. So this is symphysis menta, you can say. So if this type of structure is developed there, and if it has an opening outside but a blind thing inside, this is another example of sinus. This is pilonidal sinus. See this. This is a natal cleft between the buttock. Okay, this is the lower part of the back, and this sinus is very, very commonly present here. Pilonidal sinus. It leads to repeated infection, and there is some hair inside this pilonidal sinus. Now this is a tubercular sinus. There is a cold abscess, and probably some another form of the cold abscess is already ruptured outside and leading to tubercular sinus. So these are the different picture which tells us about the sinuses. Now some more. So please have a look here. Okay, there is one right here. Okay, on the side of the neck. Here is some pus discharge already. Okay, pus discharge because of repeated infection. So here is the mandible. Okay, here is the mandible. See here. So this is probably the hyoid bone, but very difficult to see now. Okay, I have to palpate it probably, then only I know. So this type of sinus or fistula can be anything. It can be thyroglossal fistula or sinus, and this is probably a branchial sinus which is slightly on the side. So these are the different types of example. Now one small question I like to ask. Now by just observing or inspection, can I know this is a sinus or fistula? Yes? Just by observation.
Yes, sir. Yes, sir. Yes, sir. By saying because a sinus has a outward opening, but fistula is always internal.
Okay, okay, Irfan. Any other student? Just by observation. You have not done anything else. You have not done any other test or any other investigation. Just by looking at that site, can you tell this is a sinus or fistula? Anybody? Okay, so let me explain this by myself. It is a bit of difficult thing, you know, because we are only looking at one end. Where is the other end? I'm not seeing that right now. So if that other end of the tube is also open, we call it fistula. So probably I need to pass a very, you know, a small catheter, okay, a small wire probably inside that tract. If there is no resistance felt, and it can easily go, you know, inside, uh, probably, okay, it is a fistula. But if there is a resistance, if the other end is blind, probably this is a sinus. So it is a little bit difficult just by looking at that site. That's the point. Let's move on. Now, another important part of the clinical examination is the number. Now see here, usually the sinus and fistula are single, but sometimes they are multiple, and they are usually seen in actinomycosis or sometimes even in HIV patient. These are immunocompromised conditions. Now actinomycosis, so let's talk a little bit about it. What type of organism is actinomyces? What? So I was asking you a question, okay, before the break time. What type of organism is actinomyces? Yes.
Sir, it is an anaerobic gram-positive bacteria. Sir.
Very good. Anaerobic gram-positive bacteria. Excellent answer. Very good. Now, the disease which is caused by actinomyces, especially actinomyces israeli, is called actinomycosis. It is common around the jaw area, around the neck area, as well as in the lower limbs. And it is, you know, highlighted by sulfur granules. So never forget this. Sulfur granules. This is an important MCQ question for you in the exam. This actinomycosis can result in different sinuses or formation of fistula. Sinuses are more common than fistula here, and the discharge is called sulfur granules there. Now, let's move on. Regarding the opening, okay, regarding the opening of the sinuses and fistula, if we inspect properly, we can get certain diagnosis there. Like in case of foreign body, there is sprouting, okay, opening with granulation tissue. Means a granulation tissue is growing from the outer opening of the sinus. Now granulation tissue is a, what is granulation tissue? I want to hear some answer here. This is a very common term in medicine. Yes. What is granulation?
In the chronic
blood that form itself to the wound during the healing process is wrong, sir.
there will be circulating necrosis in the center, giant cell, epithelial cell, and surrounded by lymphocytes and plasma cell.
Okay. Now let me clarify this. Okay, all of you please listen carefully here. This is a very common question which is asked in the exam. Now students often get confused between granuloma and granulation tissue. These are completely different terms. Now see that granuloma is the collection of epithelioid cell. Some of them are giant cell as well. At the center, there may be caseous necrosis, especially in case of tubercular granuloma. Okay, there are some lymphocyte plasma cells and fibroblast. That is granuloma. Don't get confused with granulation tissue. Granulation tissue is present during the healing of the wound. It's a healing process. Okay, so it is formed mainly by fibrous tissue along with inflammatory cells. Fibrous tissue with inflammatory cells from the granulation tissue. When this granulation tissue gets matured, we call this scar. Scar is mature form of granulation tissue. Now I'm sure the concept is clear for you. If it is caused by tuberculosis, I mean the tubercular sinus, the outer opening flushes with the skin, means there is no sprouting like a structure there. Okay, it is just mixing with the skin. Now let's examine the surrounding area. If it looks erythematous or red, it's a case of inflammation. If it is slightly bluish, probably it's a case of tuberculosis. If it is excoriated because of the itching, it probably is a fecal fistula. And if it is a pigmented one, then chronic sinus or fistula, okay, because of probably a lot of secondary reaction going on there. This is not a very important point though, okay, but don't forget we need to examine the surrounding area as well. Now, what is the discharge? What type of discharge coming from this opening, and what information we get from looking at the discharge? So let's talk about it. In case of tubercular sinus, a white, thin, cheesy-like discharge is coming out. This is the caseous material which is present inside, and that caseous material is just coming out. This is caseous necrosis, which is very common, thing in tuberculosis. This is a hallmark of the tuberculosis, you can say. See here, caseous, cheesy-like material. If it is coming out, this is suggestive of tubercular sinus. At the same time, you can take some other history. There would be loss of weight or loss of appetite, low-grade fever, night sweating, and all those things. If fecal matter is coming, then it is a fecal fistula. And there are so many causes for fecal fistula. One is perianal abscess rupture, can result in fecal fistula. Another is Crohn's disease as well. If sulfur granules are coming, it's actinomycosis, just talked about. Bony granules, in case of osteomyelitis, especially chronic osteomyelitis. Yellow purulent, okay, type of discharge is seen in pus-forming bacterial infection, and the most common among them is Staph aureus or Staphylococcus aureus. You can include other bacterial infection also here. It's a pus. Thin mucus-like is branchial fistula, and saliva comes from the parotid fistula. So what is the message you have got from here? We need to examine the discharge quite carefully, and from the discharge some information can be obtained. Let's move on. Now let's palpate those sinus and fistula tract and what information we get from there. Temperature and tenderness are always palpated. Now temperature means raise, okay, like for example, if there is an inflammatory reaction going on, the temperature is high and we feel it hot there. That's the meaning. And tenderness is also a feature of inflammation. So if acute infection and inflammation are going on, then that area has high temperature as well as tender. If discharge is coming after application of pressure over the surrounding area, then again, okay, it can suggest so many things. If pus comes out because of the pressure, then it is a bacterial infection there. Okay, if other types of discharge come, accordingly, so many different diagnoses can be thought. Now, induration is an important point. Induration means feeling of hardness. Okay, feeling of hardness is called induration. It is commonly present in chronic type of fistula or sinuses like in actinomycosis. Okay, it's a quite a common condition. In this regard, actually, I mean the common cause of sinus, and in tuberculosis, the sinus induration is typically absent. Palpate for the fixity. Fixity is seen in chronic type of sinuses. Okay, but having said that, whenever they are talking about fixity of the sinus or fistula or even any lymph node, they are talking about malignancy. Now, why malignancy leads to fixity of those particular surfaces or organs? Why? What is the explanation?
Sir, cancer,
That's because of
cancer has mass.
basically, sir, like
Oh,
unchanged,
because
permanent, sir, and its malignancy, sir, that also leads to it being that unchanged, sir, and it goes on spreading.
Okay, good. Now listen here, all of you, please pay attention. Malignancy has got two very important characteristic features which are not present in benign tumor. These are local invasion and distant metastasis. This local invasion is the property which is leading to fixity of that affected area. Now let me explain in some easy way. If there is malignant cells or tissues there, okay, and they have already affected the skin, I cannot pinch that skin. The skin is fixed there. If that has locally invaded the surrounding area like muscle, okay, other soft tissue, okay, even the bone, it is fixed there. I cannot move it. That is the meaning. So fixity is seen in malignancy because of local invasion property. Don't forget to palpate the deeper plane, and you can feel a lot of lymph node in case of tuberculosis, and many of those lymph nodes are matted. Okay, the border of these lymph nodes are attached with each other. This is called matted lymph node. This is a hallmark of lymph node tuberculosis. So we can get this type of information by palpation. Now, what investigation you like to order? Now, see there, please. What investigations you can order here? Let's start with CBC, or complete blood count. What is the hemoglobin level? What is the total leukocyte count? What is differential leukocyte count? And what is the platelet? We always do this. In case of acute infection, okay, the TLC is high and DLC shows neutrophilia if it is a bacterial type of infection, the pus-forming organism. But if it is a chronic type of infection, then TLC may be normal or slightly high, but when we do the DLC, it will show lymphocytosis or monocytosis. I'm sure you know these points already. Okay, so let me repeat it again. This is like a revision for the student, because you have to interpret this CBC report, and this is the way of interpretation. If total leukocyte count is high, if the disease is like an acute, okay, disease, and when we do DLC, if you see neutrophilia, this probably is an acute bacterial infection by pus-forming organism. If it is a chronic bacterial infection or any other chronic type of diseases, then total leukocyte count may be normal, but differential leukocyte count will show monocytosis and lymphocytosis. Please mute yourself. One of the student, if that happens, it will disturb all of us, okay, and I'll be distracted very easily, so please mute. Now another important one is ESR. ESR is called acute phase reactant, and this ESR is usually high in infectious and inflammatory condition. But there are certain conditions where ESR is very high, and one of that is tuberculosis. ESR is very high in TB. Never forget this. Very high means sometimes it is 50, 60, or even 70, or even more than that, millimeter at the end of 1 hour. ESR is measured like that, okay? Millimeter at the end of 1 hour. Send that discharge for culture and sensitivity, AFB stain, cytology test, and gram stain. Now, culture and sensitivity is always done from any of the discharge. I can grow some bacteria here, and if they are grown, they really help me regarding the management. That is called culture and sensitivity test. Now, sensitivity test is done after the growth of bacteria or organism in the culture plate. What is AFB stain? What is that? What is AFB stain? Who can answer that?
Sir, acid fast bacillus, sir.
Very good. Yes. So can you tell me which bacteria are acid fast bacilli?
Mycobacterium tuberculosis.
Mycobacterium tuberculosis, sir.
Good. So I just want that answer. Excellent. Mycobacterium tuberculosis or tubercle bacilli, wherever you suspect that, you need to go for acid fast bacilli stain. What is another term for acid fast stain? What is another term for that?
Nielsen stain.
Yes.
Mento test.
No, it's a stain. Okay. So it's called
Jill
Jill.
Nielsen.
Exactly. Jill Nielsen stain. So don't forget that. So let me write it. These are the things which you have to take, from this class. Okay. ZN stain, also known as Jill Nielsen stain. Jill Nielsen stain. Okay, so this, let me write this, like this. And this is also known as acid fast stain. Mycobacterium tuberculosis is the perfect example. Even Mycobacterium leprae is the another one. Now, cytology. Cytology is the term we use for the detection of malignant cells. Whenever the term cytology comes during investigation, you remember this is done to look for malignant cells. And sometimes, if we are lucky enough, but just by looking at those cells, we can diagnose which type of malignancy is this. And gram stain is done for bacterial infection. That may be gram positive or gram negative. Now, X-ray of the affected part is done to rule out osteomyelitis or foreign body. Osteomyelitis has got certain changes on the bone, especially chronic osteomyelitis. Now, before the break, we talked about some important points. So let me, highlight that once again. In chronic osteomyelitis, there is presence of sequestrum, okay, sequestrum and involucrum. Sequestrum and involucrum. Now, sequestrum is the term for dead bone, and involucrum is the term for new synthesized bone. Okay, both of these are going on together in case of chronic osteomyelitis. So when we take the X-ray, okay, some different type of density would be there. Okay, some of the areas would be, okay, osteolytic patches. Some of the area would be osteodense patches. Some more radio opaque areas can be seen. Other areas are radiolucent area as well. So this is the hallmark of osteomyelitis X-ray. Some of the foreign body can be seen, especially it depends. If it is a metallic type of foreign body, we can clearly see it there. But even if there are not metallic foreign body, because of the inflammatory reaction, because of the slight difference in the density, we can still guess something is there. So X-ray should be taken if you suspect those things. X-ray of KUB and ultrasound of the abdomen in cases of lumbar fistula to rule out Staghorn calculi. Now see there, Staghorn calculi. Now there are certain terms for Staghorn calculi. It is also known as triple stone. Okay, triple stone or magnesium ammonium phosphate stone. Triple stone or magnesium ammonium phosphate stone. Okay. Now, one of the bacteria which commonly causes this Staghorn calculi, what is the name of that bacteria?
Proteus mirabilis.
Excellent. Proteus mirabilis. You can simply say Proteus, okay? Proteus is the organism which can cause Staghorn calculi or triple stone. This stagnant calculi has a horn-like appearance, and it can really cause damage there and can lead to formation of fistula in a very rare cases. So we can diagnose it with X-ray KUB and ultrasound of the abdomen. That's the meaning. MRI can be done according to the situation. Biopsy should be taken from the edge of the sinus, especially if you suspect it's a malignancy. Biopsy has to be done. Even in tuberculosis, biopsy can be done and it will give us the positive report. So remember, in case of TB, if we get a report like this, granuloma is seen, and if they mention caseous granuloma, you got your diagnosis in 100% of the time. Probably you need to do some other test, but that is the diagnosis, that is TB. So remember the term caseous granuloma from the biopsy report. CT sinogram can be done. So we inject some of the dye into that sinus tract and take the CT scan. It can give us some important information. Okay, now see that this is another type of investigation which can be done. This is called fistulography or sinography. So just now I talked a little bit about it. We have to inject some radio opaque material inside the fistula tract or sinus tract and then take the X-ray or CT scan as well. Okay, any of the thing can be done. Now see this, look at this picture here. They have injected dye with the help of this catheter probably, and this is a tract there. Okay, look at this tract. The radio opaque substance is going inside. Okay, so for knowing the exact extent of the origin of sinus or fistula, we can go for fistulography or sinography test. And in this investigation, water soluble or ultra fluid lipoidal iodine dye is used. You can simply remember it like iodine dye. Okay, and this is consisting of around 40% of the iodine. It's a little bit more information provided here, but simply iodine dye can be injected and take the X-ray. If you see this type of structure, there is a tract inside. And how I know this is a sinus or fistula now? If it gets spilled, okay, from the inner side, if some of the dye is leaking in the surrounding area, this is a fistula. If nothing is leaking there, okay, probably this is a sinus, because in sinus one of the end is blind. Now the last part is the treatment. So what are the basic principles of the treatment of sinus or fistula? If it is an infective one, let's go for antibiotic treatment. Quite easy. Give adequate rest for the patient. Okay, excision should be done and drainage should be done. So these are the basic principles of sinus or fistula treatment. After excision, don't forget to send that specimen to histopathological exam. HPE is histopathological exam. We always need to do it, even though we are quite certain this is not a case of malignancy, but still this is a standard principle. Okay, so we should follow it and wait for the report. If it is a malignancy, you need to go for certain other type of treatment. If it is simply inflammatory condition, probably the treatment was already done by you. That is the way. Second important principle is treat the cause. So use anti-tubercular treatment for tubercular sinus, isn't it? So you need to give that TB medicine for a long duration, at least 6 months. Removal of any foreign body if it is caused by foreign body there. And in case of osteomyelitis, you need to remove that dead bone, which is called sequestrectomy. So sequestrum is the dead bone. Removal of that is called sequestrectomy. That is done for chronic osteomyelitis. Now all of you please pay attention on this slide. So see here, there is a sinus probably here. So can anybody tell me what is the diagnosis by looking at the site? What is this? What type of sinus is this? What is the name? I want quick answer. We talked about this right here in this class. Yes, pilonidal sinus.
Pilonidal sinus.
Exactly, pilonidal sinus. Excellent. Look at the site here. Okay, the upper part of the buttock area. This area is very common for pilonidal sinus. So what they have done, they have excised the whole sinus tract. See this. Okay, so where is the sinus tract now? It is excised. This is the meaning. Now let's talk a little bit about the important, type of sinus, that is tubercular sinus of the neck. The causative organism, of course, is Mycobacterium tuberculosis in most of the time, but don't forget about Mycobacterium bovis as well, because Mycobacterium bovis can also cause tubercular disease. Regarding the site and mode of infection, the lymph node in anterior triangle may be infected from the tonsil area. That is the site from where the organism may enter and go to the anterior triangle. Lymph node in posterior triangle from the adenoid, and supraclavicular node from the apex of the lung. Now, though right now we are talking about the tubercular infection, but this is the way other bacterial infection can also reach there at the lymph node of the neck. Okay, so don't forget that. If we have tonsillitis by other bacteria, that those lymph node of anterior triangle of the neck can be easily infected, okay, through this route. Similarly, adenoid can lead to infection of the posterior triangle of the neck, and supraclavicular nodes are very commonly affected from the apex of the lung. This is the common site for tuberculosis, the apex of the lung. What is adenoid, by the way? Yes, who can answer this? What is adenoid?
It is a lymphoid organ, like
Sir, there are a patch of tissue there, sir, in the throat, sir, mainly around the tonsillar region.
Okay. Yes. Okay. Good, Uzair. I want to listen again from Abbas. Abbas, you are saying something. Can you repeat it? What is adenoid?
Yes.
Yes.
Sir, it is a lymphoid organ, like sir, a tonsil.
Okay. Now see this. This is an important question. Okay. But many of you probably do not know the answer because we have not taught you before regarding this. There are 4 important group of tonsils on our head and neck area. So let me write the names of those. Let me utilize some time regarding this. These are called different groups of tonsils in head and neck area. Out of them, the most important is called palatine tonsil. The palatine tonsils are the biggest form of the tonsils, and these are the tonsils which we examine every time. If you suffer from tonsillitis, these are the tonsils which are enlarged. So palatine tonsil. The second, okay, is called lingual tonsil. Lingual. This lingual tonsil is present on the base of the tongue, on the back side, on the base of the tongue, we say lingual tonsil. The third is nasopharyngeal tonsil. Nasopharyngeal tonsil, and this tonsil, when it is enlarged, it is known as adenoid. So this is nasopharyngeal tonsil. Don't forget, adenoid is the enlarged form of nasopharyngeal tonsil. And the last one is called tubal tonsil. Tubal tonsil means it is present at the opening of Eustachian tube at the nasopharynx area. Remember Eustachian tube, also known as auditory tube. So where is that auditory tube is connecting? Which 2 structures are connected by auditory tube? Yes, which are those 2 structures?
Eardrum and cochlea.
Middle ear to nasopharynx.
Middle ear and nasopharynx. Excellent. Okay, middle ear and nasopharynx. Very good. So that is a connection which is known as auditory tube or Eustachian tube. At the opening in the nasopharynx, okay, of that Eustachian tube, there is a group of lymphoid follicle which are called tubal tonsil. So this is very common questions or favorite questions of the examiner, and This is commonly known as one of the term, and that is called Walder's ring. Now see here, these tonsils are, you know, organized in a ring fashion. So this is called Walder's ring. 4 group of tonsils are there. Tonsils are nothing, they are a group of lymphoid follicle, and if we take a histopathology from there, then we can see the collection of the lymphocytes there. Okay, that's the point. Now let's move further. What are the clinical stages of tubercular sinus formation? Very important question in the exam. So all of the students, please pay attention on your slide here. In stage 1, there is lymphadenitis, means inflammation of the lymph node. And when we palpate those lymph nodes in case of tuberculosis, now see here, what are the characteristic point? They are discrete, non-tender, firm and hard in the beginning, and later on they are matted. In the beginning, they are discrete, means individual lymph node can be felt. This is the meaning of discrete. But later on, the peripheral part of each of these lymph nodes will be attached with each other, and this is called matted lymph node, which you can see in stage 2. It depends in which stage you are examining the patient. Okay, if patient comes in stage 2, then I cannot find this type of finding now. I am already palpating the matted lymph node. That's the point. And one of the very important point is these lymph nodes are non-tender. Remember this, though tubercular organism is a type of bacteria, this is a chronic sort of bacteria, and there is no tenderness during the palpation. Whereas acute pyogenic bacterial infection always leads to tender lymph node. After this stage 2 or matted lymph node, now see there is a development of cold abscess. At the center, you can clearly see there is a liquefaction developing. Okay, liquefaction developing, but we don't call it liquefactive necrosis, we call it caseous necrosis in case of tuberculosis. And at the peripheral part of that cold abscess, we can still feel some of the lymph node. It is deeper to the deep fascia. Now what happens is a part of the abscess is coming upwards, okay, coming upwards, and a part of the abscess cavity is still lying deeper to the deep fascia, and this is known as collar stud abscess. This typical appearance is called collar stud abscess. It has ruptured superficially through the deep fascia. One part is present superficial to the deep fascia, and another part is present still deeper to the deep fascia. Collar stud abscess. This is very important one. And lastly, when the superficial one ruptures outside from the skin, we get sinus. This is called tubercular sinus. Only one end is open, you can clearly see here, the other end is blind, or it has led to the cavity. Now to elaborate this a little bit further, this is the stage of cold abscess. So let's talk a little bit about it and look at the picture here. Okay, there is a huge swelling. There's a swelling. There's slight redness on the surface of the swelling. But when I touch this area, there is no pain. Number one. Number two, it doesn't feel hot because the signs of typical inflammations are absent here. So this cold abscess is present because of caseating necrosis. Every student know now. It is non-tender, cystic, and fluctuant swelling, which is not adherent to the overlying skin. It's a fluctuant swelling. Now what's the meaning here? There is some collection inside. Probably there is a caseous necrosis material inside. Okay, or you can say some type of pus. But this pus is very different from other bacterial infection pus. Sternocleidomastoid contraction test would be positive because it is present deeper to the deep fascia. That is the point. And the transillumination test is negative. Now what is transillumination test? Anybody? So let me explain this. Probably we have not talked about this in the prior classes. Okay, so listen carefully. I need to make that environment a little bit darker first. So close all the curtains, okay, and close the windows and the doors. That's the first thing. Second, take a small torch and put that torch on one side or one end of the cystic mass and look for the illumination. Look for the brightening. If it doesn't brighten, the whole mass doesn't brighten up, then trans illumination test is negative. If it brightens up or illuminate, that means it is positive. Now what is the conclusion here? If there is clear fluid inside the cyst, then trans illumination test is positive. If there is pus, okay, pus is not a clear fluid, okay, this test would be negative. So trans illumination test is negative in case of cold abscess. Now let's talk about stage of color stud abscess, but students they have already known this. The cold abscess, when it ruptures through the deep fascia, forming another swelling in the subcutaneous plane, this is called color stud abscess. So one part of the abscess is superficial and another is deeper, and there is a connection between the two. It is a fluctuant swelling which is adherent to the skin, and we should treat it like a cold abscess. So treatment doesn't have any difference. There is a picture which is showing you about color stud abscess. Okay, it is difficult to identify from the picture because we need to feel for it, we need to palpate for it. Okay, so there is a deep abscess which is shown by this arrow, and this is a subcutaneous abscess which is shown here. But let me remind you again, rather than inspection, we need to palpate for this color stud abscess. Another stage is the stage of sinus formation. That what our topic is all about. So color stud abscess, when it bursts or rupture outside, it leads to a sinus formation, and this is a persistently discharging sinus. And what type of discharge comes out? The caseous necrosis material, it comes out. Usually it is a single one, but sometimes it can be multiple. Okay, it can be multiple, and it has a slight bluish discoloration around the edges, which is not very important finding. And one of the important point is there is no induration, or there is no hard filling around the tract, and this is probably explained by lack of inflammatory changes there. Now let's do this quickly. This is the not a new thing for you. You have studied this investigation of tuberculosis so many times. CBC, hematocrit, total leukocyte count, differential leukocyte count, platelets are always done. ESR is usually high in case of tuberculosis, and serum albumin, if the patient is malnourished because of chronicity of the disease, serum albumin will be low. FNAC, or fine needle aspiration cytology, can be done of the lymph node, and the material is sent for acid fast bacilli stain as well as culture and sensitivity. Now what is the culture media for tubercle bacilli? Which culture media is used? Yes, quick answer.
Acid fast bacilli.
What's the name of the culture media? Lowinston-Jensen media. Okay, LJ media. Lowinston-Jensen media, or LJ media is the name. After that, we can take biopsy of the lymph node if this is not confirmatory. In case of sinus granuloma, the edge biopsy can be taken because from the center you can only get the caseous necrose material, but if you take from the edge, you can see the granuloma. That is important point. Mantoux test is always done if tuberculosis is suspected, but there are different way of interpreting it. Okay, don't give a lot of value to the Mantoux test alone. If it is present with other type of investigation, or if it is done with other investigation, I should say, then it has more yield rather than doing alone. Chest X-ray always done if TB is suspected, and sputum should be tried, okay, and if it is coming out, then we should send for acid fast bacilli stain. But many of the time sputum doesn't have any acid fast bacilli at the time because it has already gone out of the lung. Okay, so these are the investigation. Okay, so another type of investigation which is important in the diagnosis of cold abscess is ultrasound of the neck, because that is a common site for cold abscess formation. So if we do ultrasound of the neck, we can see hypoechoic lesion with internal echoes, and these internal echoes are suggestive of debris within the abscess. We can also go for guided aspiration of cold abscess and confirm it. Okay, so this is important type of test, that is ultrasound of the neck. Now the final part is the treatment. So how we treat cold abscess and how we treat tubercular sinus. Let's talk about it. If it is still in the stage of cold abscess, we can go for aspiration, and this aspiration is done by zigzag pattern in the non-dependent area, because if we do incision and drainage, which is actually contraindicated in this situation, if we do that, we can turn this abscess into a persistent sinus. So incision and drainage is not done, and we can go for zigzag type of aspiration. At the same time, you can instill 1 gram of streptomycin with or without isoniazid in solution in that area, and do not put a drain or place a drain after that. If you place or put a drain, you can turn that abscess into a sinus again. At the same time, you start ATT and continue it for a long time, usually 6 to 8 months. If sinus is already formed, okay, you have to go for excision of the sinus tract. You have to remove the sinus tract, and at the same time remove the diseased lymph node as well, and ask the patient to take ATT for a longer duration. So this is how we manage the cold abscess and sinus formed by tubercular organism.